Okay. Hi, I'm Dr. Josef Witt-Doerring, and for today's interview, it's my pleasure to say that we've got Dr. Alan Francis here. Alan Francis, he was the chairman of Duke Psychiatry, and he also led the team that wrote the DSM-4. I would say it's fair to say that Dr. Francis has been at the center of establishment psychiatry, and he's also a respected leader kind of, within that field. About 10 years ago, he started to very publicly raise attention about some of the limitations of our current mental health system. First, by talking about the DSM and the way it's misused, but also generally about the different kind of incentives that have led to suboptimal mental health care in the US. So we're going to have a discussion about specifically about benzodiazepines and antidepressants. And on that note, I'm going to turn it over to Dr. Francis, who's going to tell us a little bit about the history of these medications and how they came to be used. So thanks for being here.
Well, I was part of the new wave of psychiatrists in the 70s that were thrilled when the benzodiazepines came on the market because they seemed to be so all-purpose helpful, wonderful for detox. The hope was that they could be a replacement for alcoholism with many fewer side effects. And then I came to realize very quickly when I ran a drug and alcohol program that the patients who you switched to benzodiazepines wound up taking more alcohol and more benzodiazepines together and got into lots of trouble. And I realized in the early 70s that this was a very dangerous medication. I think people need to understand why they became so popular. Why are benzodiazepines so popular? So currently in the US, 4% of people, 4% of the general population of the US is on a benzodiazepine. 8% of the population of geriatric patients, elder seniors, is on a benzodiazepine. And that's particularly striking, twice the general population rate in elderly because it's so dangerous in the elderly with falls, memory impairment, confusion, delirium, all tremendous risk factors in the elderly. Why are these medicines so popular? Well, the first villain in this piece is Arthur Sackler. People are probably familiar with the Sackler family's villainous role in promoting the opioid horrible epidemic that's now completely out of hand with the introduction of fentanyl. The Sackler family has been an absolute tragedy in American history. And the opioid epidemic is only the latest example of this. Sackler, during medical school, worked for a Madison Avenue advertising company. He bought the company early in his career, and he became the advisor to Roche, which produced both Librium and Valium in terms of their advertising. And he invented most of the horrible tools of drug company advertising during the 60s and 70s. The idea of having thought leaders, of having advertisements, beautiful detailed people to visit doctors and push the product. And most importantly, the idea that the psychiatric medicines should be used by everyone, not just psychiatric patients. So he developed an advertising campaign for Librium and Valium that emphasized the fact that these were anti-anxiety drugs that helped everyone. You didn't need to have a psychiatric disorder to benefit from them. And they emphasized the relative safety and the enormous efficacy. And the drugs quickly became among the best-selling drugs in America, very quickly, and very soon after that, best-selling drugs in the world. So the original sin of the benzodiazepines rests with the Sacklers, goes back 50 years now. The second edition of this was with the introduction of Xanax, and I think it was 86 or 87. And I actually saw some of the early data that was being produced by an international collaboration of researchers on Xanax. And it turned out that the dose that was used for panic disorder, that was effective for panic disorder, was very close to an addicting dose. From the company's perspective, this was shockingly a good thing, not a bad thing, because it meant that the people who used the medication for panic disorder would essentially be hooked on it, and they would be lifetime customers. And in my view, the indications for the use of benzodiazepine are vanishingly small in psychiatry. The only uses of benzodiazepines that are worth the enormous risks are in catatonia, because it has a dramatic effect in improving catatonic patients. So does ECT, but benzodiazepines are dramatically effective in catatonia, but that's a relatively rare condition. It can be useful and is useful in detox. It's useful in some neurological conditions. It's useful maybe in some emergency situations where there's a need to instantly reduce agitation. It might be useful for the first few weeks in panic disorder until the SSRI or the psychotherapy kicks in. But the risks are so high of patients becoming hooked on it that I would see that as basically a risk-benefit ratio I'd be very unwilling to take for most people. So by and large, you have a medication that's very popular. Patients love it. It's like being able to get the relaxation from drinking alcohol in a pill form. It's very popular. It works in terms of immediate short-term benefit, but the long-term ridiculously high risks are never considered during the initial period of prescription. And the worst part of the story is that 80% of the benzodiazepines are prescribed, at least 80% of the benzodiazepines are prescribed by primary care doctors, not by psychiatrists. And they're usually prescribed after about a 15-minute visit. The most important thing for doctors in America these days is getting the patient out of the office quickly. The easiest way to get a patient out of the office quickly is to give them a benzodiazepine, because the medicine will make them feel better in the short run. And the long-term considerations, all the risks that come with addiction and overdose, are ignored by the primary care doctor because he doesn't have time to think about that. He has the compelling injunction from his boss to get the patient out of the office very quickly. So patients are never educated about the risks, are always plugged into the benefits. In the long run, that's led to the disastrous situation with millions and millions of people on medicine that they can't stop. It's very hard to stop benzodiazepines. It's a very long, very dangerous withdrawal period unless it's done under careful supervision. It has to be done very slowly over months in most cases. And so we have the situation where millions and millions and maybe tens of millions of people are on medication they no longer need, no longer benefit from, that has all of the risks of dependency without any of the benefits of efficacy.
Mm-hmm. Yeah, thank you for that overview. I want to pick up on a thread there. This is something you've spoken about at length before, but it's that thing you said about the incentive being to get the patient out of the doctor's office kind of as quickly as possible. And certainly that was my experience when I was going through training, and it's been something that I've seen recently. Whether it's the way psychiatrists are reimbursed for treatment. I mean, you get more reimbursement if you do 4 15-minute visits as opposed to, say, doing a 15-minute med check and then combining it with 40 minutes of psychotherapy or something like that. And so I mean, that is also a factor. Then there's also things like RSUs, which are these incentives given to physicians to kind of see patients over their typical quota, and then they get bonuses at the end of the year for that. And I mean that's something I'd like to get your perspective on, because I feel like when that kind of incentive model to see people in shorter periods of time is kind of led up with things, kind of combined with things like the DSM, you don't really get I guess physicians who are really getting to know their patients in the context of the stresses in their lives. It becomes almost this searching for what symptoms do you have? And okay, you have these symptoms, and now we have a drug that meets that indication. And then, like you said, it's prescribed and they kind of leave. So yeah, I'd like to get your perspective on, how you think psychiatry is practiced in the US today. And I guess what you think of the key, the main drivers of the way it's practiced.
Well, again, psychiatry is only a small part of the problem. That at least 80% of the medications are prescribed in primary care. Yes. So even if we had perfect psychiatric practice, it would not even begin to touch the magnitude of the overprescription and careless use of medication, particularly the benzodiazepines, which have so little utility in our field. I think that, as you mentioned, all of the incentives are in the wrong direction. Any jerk can write a prescription, and many do. And particularly if you only have 15 minutes with the patient and you never get to know their problems, the context of their problems. Most of the problems people present with to primary care, and many of the problems that people present to psychiatrists, are more psychosocial than they are biological, that are related to current stress, loss of support, grieving, financial distress. Social and psychological problems are an enormous driver of people to want some sort of pill solution to a problem that often doesn't lend itself to chemical agents. And it takes much more time up front to be able to talk to people, to get to know them. Hippocrates said it's more important to know the patient who has the disease than the disease the patient has. That in order to understand the psychological and social context of a given symptom, you have to know the person, and that requires time and expertise. In order to write a prescription, you just have to have the MD and the ability to say, I'm going to give you this medicine. You don't have to get to know the patient. You don't even have to know the medicine very well. And so many prescriptions for psychiatric medications are written by people who are not very well trained in psychiatry. And even if they are, have very little time, certainly not enough time to get to know the person and explain the other options. For most mild to moderate problems, particularly transient ones that patients present with, time, watchful waiting, and placebo effect are much more powerful than any active, useful efficacy from the medication. So for most mild to moderate problems, talking to people, getting to know their situation, providing advice, support, reducing stress, simple psychotherapeutic techniques will be far more useful than medication. In the long run, far less expensive. Once you're on a benzodiazepine, there's a very strong pressure based on tolerance to increase the dose. And as the dose gradually rises, often it will be very gradually and over many years, the ability to get off the medicine becomes less and less. And the symptoms that arise from deprescribing more and more risky. So that people are trapped often into a lifelong dependence on medication for transient stress-related environmental and psychological problems that would have been dealt with much more efficiently with a good evaluation, psychoeducation, and psychotherapy at the outset. Medication is the easy, cheap thing to do in the short run that turns out to be very, very difficult and expensive in the long run.
And would you extend that same kind of train of thought to the use of antidepressants for, mild to moderate depression as well?
Yeah, I think that the antidepressants became remarkably popular with the advent of Prozac, and again, same time, around 1987, with the notion that they didn't have the difficult side effects of the older antidepressants, although they have their own package of side effects. And at the beginning, it wasn't really clear that they had withdrawal symptoms. It's become increasingly clear that for many people, it turns out that a very large percentage of people who start an antidepressant stay on it for a long period of time. This despite the fact that most of the people who seem to get a benefit from the antidepressant from mild to moderate problems are probably placebo responders. So if you have a mild to moderate short-term depression, the odds of a placebo response are over 50%. The odds of a drug response are maybe 60 to 70%. There's very little added advantage of the active ingredient in the medication when you're dealing with mild to moderate depressions. Most of the response has to do with the passage of time and the expectation of recovery. But if you start a medicine at the beginning of at the end of a visit with your primary care doctor or psychiatrist for a transient depression, and you get better in 3 weeks, you don't know that you got better because of time and placebo effect. You think you got better because of the medication. And many people will stay on medication for many, many years, sometimes decades, that they may not have needed, but have a great deal of trouble getting off.